communities that we represent, they are microcosms of smaller cultures. For example, what you see in Mindanao might not be the same in other parts of the Philippines. The same way in the north of Thailand and the south of Thailand, there will be different cultural norms as well. Religion plays a big part in how people actually perceive whatever challenges that come to them in life, whatever anchor, whatever spirituality that they belong to. The same, therefore, will then create challenges for patient groups like ours in engaging the population and the families that we meet. Do we go down the route of how do we give the best life possible? Do we go down the route of, how many of you here would have been told by a patient or a patient family that says, I was told by my priest or my shaman or my witch doctor, if I take this water, my kid's gonna get better. If I go and pray at this cemetery, I'm gonna get healed, right? See?
Yes.
Okay, so while we're talking science, patient groups have the challenges of demystifying the gobbledygook that we're told, right? I have been told many times that, from parents who are actually even healthcare professionals and doctors who are saying, Nadia, I was a doctor for X number of years until I got a child with rare disease, until I was diagnosed with a rare disease. And then I realized that science is one thing, but faith is another. And faith sometimes, coupled with hope and desperation, is a very lethal thing. And then you start doing things that you know in your mind, this won't work, but you're running on hope, right? The other thing I just want to highlight, the last part, is geography. In Malaysia, up till today, the equity of health and access, or everything that we want to do for rare disease, of course, is challenged by distance, reach, and accessibility of one location to the next. So where a lot of the clinics that are focused on genetic testing, newborn screening, access, the professionals are all in Klang Valley or in the peninsula of Malaysia, Borneo and Sabah and Sarawak, which is actually separated by mountains and hills and rivers and tracks, similar to what's happening in Indonesia with the thousands of islands and the Philippines as well, is distance and reach. Now, geography means that we have to have better infra, we have to have better ways of reaching people, and we have to have better services that allow, it can be telehealth, it can be many different modalities, innovation, to be able to reach. And until that is adapted, that will also continue to be a challenge.
Thank you, Nadia. Nadia highlighted another set of challenges. Political will, succession planning, so that it's not going to be waxing and waning, as the Jedis leave this world. The next part is culture. It's true. In this room, we have so many cultures. How do you treat somebody from up north to the south? And of course, the last part that she mentioned was something we don't discuss, but she said, at one point, there is the combination of faith, hope, and desperation. And as she said, that is dangerous. So let's move on to our third speaker. We have Dr. Wang. And which question did you choose? Dr. Wang?
Okay, I'll choose the, not sure, but I know what I'm going to say, regardless of the question.
She decided to answer her own question. Okay, go ahead, Dr. Don.
All right. So I think the greatest challenge to get the new innovation therapy, because it's very high cost, right? So I think the most difficult one is the first step. When I mean the first step, I meant to say about the first case, the successful story of the patient that can get treatment and have a good outcome. So whenever I had a chance, I would tell the other specialty who come to consult me how we can get this man onto the under the coverage. I would say find the right patients and get the treatment, the early access program. So that will need support from the industry and show that case to the community, so that they can see that it can be done really in the country, not just in the journal or paper publications. And I think that will help us to go to the second step. And after they see that, they will have a more political will to help. And secondly, by doing healthcare professional education, because most of rare diseases are not deeply or well taught in the medical school, because we tend to teach our medical student or even specialty to attack more common disease. And some of these rare diseases require a very specialized, specialization to treat the patient and also see the whole picture. So I think the CME or even at the academic meeting, it needs to, to be taught or talk about, and I think that will be able to engage more doctor and more specialists. Secondly, for the long term, besides the political will, we also need the medicine to be registered in the country. Otherwise, it will not be for the benefit package in long run. And thirdly, we are always asked if we have a clinical guideline in the country. And it's quite difficult because the international clinical guideline is there, right? Can we borrow them? Sometimes we can, and most of the time we can, because the regulatory and the policy would like to see the local guideline. And the reason for that is that, are you sure, doctors, that we have the same type of disorder as that the other country have? Are you sure? Are you sure?
Apologies, let's fix it first.
And are you sure, doctor, that that clinical guideline will fit our patients? And are you sure that the medicine will work for our patient? So the clinical guideline will be also necessary for make the treatment become under the benefit package. I still have 1 minute. So may I have my slide, please? Just 2 slides. Go to the second. Okay. The continuing conversation with the regulatory and the HTA is important. For example, when we start the rare disease policy in 2019, we borrow criteria from the general disorder and adapt a little bit of it. For example, you can look at the severity, right? At first, if dead, you get a higher score. But now we start